Welcome to this webinar today. I'm Dr. Bernard Filner. I'm in Rockville, Maryland at the present time, and today we're going to talk about general chronic pain and treatment with the low-level laser. During this webinar and afterwards, we want your feedback. During the presentation, please ask any questions in the live chat as well as give us any particular feedback, positive or critical. We want to continue to enhance our viewer experience with your help. My experience in treating patients has been that I was originally an anesthesiologist for approximately 19 years. At the time, after approximately 19 years, I developed Meniere's disease and had to stop working in the operating rooms. At the time, I had met Dr. Janet Travell several years earlier, and she helped me get started in a practice of pain medicine, which I have done since 1987. I worked with Dr. Travell for 10 years before she retired and moved to Boston. For the first 15 years of my practice, the main tool we had to inactivate trigger points was the trigger point injection using a local anesthetic, and I did more than 250,000 of those during those first 15 years. During the last 4 years, the number of injections has dropped from a high that gave me that total of 250,000 to an average of 50 per week, and is now down to only 4 patients, so that would probably mean close to 40 or 50 trigger points per week. In the last 7 years, I have inactivated more than 120,000 individual trigger points with the low-power laser, and we'll get to some discussion of that shortly. If you're treating chronic pain, this is probably the most important message you will take away from this webinar and perhaps any other lectures you might or seminars you might hear, and that is to think outside the box. You can't simply be following the old rules and things you learned 25 years ago in school or in a residency program or in your practice over the last period of time. You need to think outside that box, and usually that means dealing with something called myofascial pain, and we will get into a detailed discussion of that as we proceed. Now remember, pain is a very subjective symptom and varies from patient to patient. There is a scale called the VAS, or Visual Analog Scale, a scale from 0 to 10 that has been demonstrated to be very, very accurate and predictable between times, but in the same patient, not between patients. In other words, people are very consistent in their pain thresholds, and if you compare their pain reports from week to week on the VAS scale, it is highly valid. However, you can't compare the pain score from one patient to the pain score for another, because people have a very different pain threshold, and they cannot be compared one person to another. Objective signs are frequently not present or not found when you're dealing with chronic pain. But trigger points are objective. You can feel them, and you can feel when they're gone. And if you've been trained to find them and you are skilled at finding them, you will find them if they're there. And if you don't find them, that means they are not there. It's important to remember that in many ways your hands and what they palpate are at least as objective as most imaging studies. And the final thing to remember is that diagnosis is the key. If you have the wrong diagnosis, you'll probably go down the wrong road in terms of treating the patient, and they will not get better. So it's really important to get the proper diagnosis, which almost always will include myofascial pain. And that's, again, we'll discuss that shortly. The old definition of chronic pain was, quote, pain of more than 6 months duration for which an organic basis cannot be found, unquote. And this was the basis for most of these patients being referred to psychologists and occasionally to psychiatrists because people could not find any organic reason, and then it was felt that it was basically a psychosomatic problem and had to be dealt with by the psychology people. And clearly the problem here was that the diagnosis was not made because people did not either know of or could not find these myofascial trigger points. So this definition of chronic pain is no longer acceptable. There is such a thing as a chronic pain syndrome, where patients present with pain, they're depressed, and every patient with chronic pain, truly chronic pain, is depressed. If they're not, they have major psychiatric problems. They're deconditioned, and they're dependent on all sorts of others rather than themselves. And this others can be an insurance adjuster, family member, their doctors, or their therapists, etc., so that they are highly dependent on them for not only validation, but for taking care of many of their needs, particularly for medications. And they frequently exhibit a drug-seeking behavior, not because they're addicted. Very rarely do chronic pain patients become addicted just from the medications that you give them for their chronic pain. If they become addicted, usually it's a situation that's been true in the past that now surfaces again when they are given opiates again. Physical dependence occurs with many different medications, but certainly with opiates, and that can relatively easily be dealt with simply by tapering in an appropriate way. And pseudo-addiction is a very common phenomenon among patients with chronic pain because they are often labeled addicts because they are often seeking medications and become very open about seeking medications, and people looking at them superficially will say, well, they're addicts. But in fact, what's happening is they've been undertreated in terms of their medication. They still have pain, and therefore they are asking for adequate medication to treat their pain. So they're not addicted, but we call that pseudo-addiction. True addiction is variously defined, and some people will define it as using a medication for a purpose for which it was not intended, such as to get high when in fact it's intended to relieve pain. People who in effect sacrifice their life and their family and many of the aspects of their daily lives in order to obtain medications and drugs are in fact addicted because they exhibit this behavior in spite of the negative consequences that may even be apparent to them, but they simply deny the validity of these consequences, so they continue to be addicted. Within the definition of chronic pain, probably the most common is a myofascial pain syndrome. Fibromyalgia is a common, relatively common affliction. Arthritis is probably at least as common, certainly in the older population, as a myofascial pain is. Chronic headaches, back and neck pain, including the so-called failed surgery, where a patient has had surgery and continues to have pain after the surgical procedure. Carpal tunnel syndrome, reflex sympathetic dystrophy, which is now called chronic regional pain syndrome, or CRIPS. Temporomandibular dysfunction, which should always be the label that you apply to the musculoskeletal problems that people have related to their muscles of mastication, since many insurance policies will disallow all treatment if it's at all related to temporomandibular joint problems. And that's often written into the main contract. So you don't want to put into the patient's chart that they have TMJ unless there's actually a problem inside the joint, which is very unusual, and almost always requires some sort of surgical procedure to deal with it. Pelvic pain is often of chronic nature, migraine, neuropathic pain, tennis elbow, frozen shoulder, and post-breast cancer surgery. You'll find a lot of these patients somehow think that the pain or the swelling that they have in their arms and a number of other symptoms are simply a function of their having had cancer, and that they therefore just accept the fact that they aren't going to be able to move their shoulder normally. And this should not be accepted, because especially if it's treated early, it can easily be resolved. The key point to remember as we go through this is essentially all cases of chronic pain have some component of myofascial pain, that is trigger points, as part of their pain pattern and pain complaints. So you'll always find some. If it's primary and solely responsible, then it's a myofascial syndrome. If it's secondary to a nerve root compression by a disc, then it's radicular pain with secondary myofascial pain, and you need to deal with both of those problems. But in any case, in any treatment program for people with any kind of significant chronic pain, you need to search for these trigger points and inactivate them as part of the overall treatment of the condition. People often think that stress causes these problems. It does not. People who are severely stressed do not develop myofascial trigger points unless they've already had them. If a patient already has a problem with myofascial pain, stress will aggravate it significantly. On the other hand, and may set off significant flare-ups. On the other hand, stress alone will not cause this problem. Now, who should be treating chronic pain? Basically, anybody who's willing to develop the skills and to devote the time that it takes to treat these pain patients. Their treatment is often complex and takes significantly more time than a patient coming into a practice with a cold or a sore throat. The diagnosis is most important, again, and this is clearly done primarily by history and physical exam, but also on occasion one needs to use imaging early on, and certainly even using the low-power laser as a diagnostic tool to see if that resolves the problem, using essentially a no-risk procedure may be an important help to making a diagnosis. If you make a diagnosis or you can't, or if the diagnosis is such that you don't feel confident to treat it yourself, then you need to do the appropriate referrals. And avoid the 6 blind people syndrome. This is the 6 blind people in a room with an elephant, and each one describes the elephant in a different way. That often happens in our medical system now, where each individual who sees a patient uses their own terminology and looks only for their particular area of interest as a pathology. And clearly one needs to be able to see the entire animal. And another thing to remember when you're dealing with colleagues who you will inevitably need to deal with when you're dealing with chronic pain problems is that nobody and no one is right all the time.